Good evening, delegates and participants. Thank you for joining Shield Connect today. And today we have a special doctor from Odisha, Dr. Sayamstuti Patnaik, and ma'am is going to speak about UTI in women's health. So before we start with the session, let me give a little introduction of our page Shield Connect. So this is
Nishant sir, your voice is not coming.
Yeah, Mr. Nishant, just check. Nishant?
sorry. It was on mute.
Okay, you can
Okay.
restart. You can restart.
Okay. Welcome all the participants for today's webinar. And today's webinar will be conducted by Dr. Sayamstuti Patnaik. Ma'am is going to take topic UTI in women's health. So before we start with the session, let me give a little introduction about our page Shield Connect. So this is our page where you can find different sections are available. The first section is the blog section where you can find all the blogs written by the eminent speakers and doctors. Then we have the webinar section where you can find all the different webinars that we are conducting. And you can also click on the today's webinar. So you will find the webinar that is ongoing. And just you have to post your queries in this comment section so we can have a Q&A at the end of our webinar. Then we have past webinars where you can find all the webinars that we have conducted till now on Shield Connect. Then we have different awareness pages like PCOS, menopause, GDM pages. So if you click on any one of the pages, you will find all the blogs and videos regarding the topics like menopause. So you will find all the topics regarding menopause. And then we have our leader section where you can find all the detailed profile of our speakers and doctors who are connected with Shield Connect. So this is our page Shield Connect. Now let me give you a brief introduction of our speaker, Dr. Sayamstuti Patnaik. So ma'am is a consultant obstetrician gynecologist, laparoscopic surgeon and infertility specialist in Shanti Memorial Hospital, Rourkela from Odisha and pioneer in ART in Odisha. Ma'am has done MBBS from Utkal University, MS in obstetric and gynecology from RGUHS, Karnataka, fellowship in reproductive medicine from Germany, fellowship in minimal access surgery from Belgium, fellowship in fetal medicine. Ma'am is also member of different societies like ASARM, ASHRAE, AAGL, FOXY, ISAR, IFS, and PCOS Society. Ma'am is trained in Bourne Hall Clinic in reproductive medicine. Ma'am is also trained in laparoscopy and gyneco-oncology in Galaxy Care Hospital, Pune, under Dr. Shailesh Puntabikar. Trained in fetal medicines in Karthik Ultrasound Center, Bengaluru, under Dr. Chitra Ganesh. Ma'am is also trained in laparoscopy in endoscopic training center in Antwerp. And ma'am also presented many papers like national and international presentations, including AAGL 2019 in Vancouver. And recently, ma'am is also winner of best paper of a CS Down Prize in AICOG in 2022 in Indore. So we welcome ma'am on our platform for today's session. And ma'am, one more message from Shield. We greet Dr. Monu Patnaik sir and madam. Very happy marriage for today.
Thank you. Thank you so much. Thank you so much for yeah. Shall I share my screen now?
Yes, ma'am.
Yeah, is it visible?
Yes, ma'am.
Slides are changing.
Yes, ma'am.
Yes, ma'am.
Okay. Very good evening to one and all. I'm thankful to Sheil for giving me this opportunity to speak on this topic UTI, which is a very common topic, but we find a major chunk of our OPD comprising of problems related to urinary tract and its infection. So I think it is very, very important and pertinent for everyone to know a few basics and a few advancements that have happened in this field and in this topic. So without wasting much time, let's just go through this topic, and I hope this is going to help and be informative to all those who go through it. Urinary tract infections have been described since ancient times. First documented description in Eber's papyrus dated to circa 1550 BC. It was described by the Egyptians as sending forth heat from the bladder. Effective treatment did not occur until the development and availability of antibiotics in the 1930s, before which we had various other means like herbs, bloodletting, and rest, which were recommended. And sometimes it went untreated and undetected, even causing serious problems, which was not at all diagnosed, or the root of it was not a urinary tract infection, and the unawareness about it. By convention, UTI is defined either as a lower tract acute cystitis or upper tract acute pyelonephritis infection. UTI may be asymptomatic, which is a subclinical infection. We may not be having any symptoms, or symptomatic, with which the patient comes into our clinic. Thus, the term urinary tract infection encompasses a variety of clinical entities, including asymptomatic bacteriuria, cystitis, prostatitis, and pyelonephritis. Coming to asymptomatic bacteriuria, which occurs in absence of symptoms attributable to the bacteria in the urinary tract and does not usually require treatment. UTI has more typically been assumed to imply symptomatic disease that warrants antimicrobial therapy. The additive parameters of UTI classification and severity assessment. How do we classify this problem, and how do we know in which category of severity it exists, and how do we manage the treatment? So coming to the clinical presentation, whether it is starting from urethritis, then to cystitis, then to pyelonephritis, followed by urosepsis or male genital glands. Grade of severity, as we can see here, low, moderate, severe, organ dysfunction and organ failure. Risk factors, as we can see, no risk factors or recurrent UTI. These are the various terminologies and the various gradings that we can see here. Extra urogenital risk factor, nephropathic risk factor, urological or catheter being the risk factor. Various pathogens like species susceptibility grade of it, reduced susceptibility, and multi-resistant species if we are going to find in the culture. So coming to SIRS, systematic inflammatory response syndrome, which is also one of the grades of severity due to UTI. This system classifies urinary tract infections in males and females, and therefore male genital glands under clinical presentation is inapplicable in our context of discussion, but still we can have the involvement of male genital glands also, like prostatitis and other things. So we can see the various grades 1 to 6 coming to the grade of severity, the risk factors, ORE, NUC, as you can see here, depending upon the pathogens. And coming to epidemiology, asymptomatic bacteriuria, we find it among 10 to 13% of the people, acute cystitis in 1 to 4%, acute pyelonephritis in 0.5 to 2%. Though incidence of bacteriuria in pregnant women is only slightly higher than non-pregnant women, the chances of progression to pyelonephritis is significantly higher, that is around 40%. The rate of recurrence has not been calculated by any RCT or a major study. The various causative pathogens, as we know, most UTIs are caused by a single bacterial species. At least 80% of the uncomplicated cystitis and pyelonephritis are due to E. coli. When we see majority of our culture specimens that we get, the reports that we get E. coli, with most of the pathogenic strains belonging to the O serogroups. Other less common uropathogens include Klebsiella, Proteus, Enterobacter species, and Enterococci. In hospital-acquired UTIs, a wider variety of causative organisms are found, including Pseudomonas and Staphylococcus, which becomes even more difficult to treat. UTIs caused by Staphylococcus aureus often result from hematogenous dissemination. Group B beta hemolytic streptococci can cause UTIs in pregnant women. So we have to look forward that we need to find out the real pathogen when we are going to find recurrence, or we are finding a different cause. Suppose a woman has been admitted in the hospital. Post that, we need to find out the history. We need to find out what probable causative organism would have caused it, and accordingly start our treatment instead of blindly just terming it as UTI. So the various predisposing factors to UTI, the factors which increase the urinary stasis, that is when we have the urine staying inside the bladder for a longer time, intrinsic obstruction due to stone or tumor in the urinary tract, extrinsic obstruction due to tumor or fibrosis, urinary retention including neurogenic bladder, any renal impairment. Also foreign bodies like a urinary tract calculi, due to a catheter being staying for a longer time, urinary tract instrumentation also. So these are the various predisposing factors which lead to a urinary tract infection. Various anatomic factors, what do we find? Congenital defect in the genital tract leading to obstruction, any form of fistula, a shorter female urethra, that's why we find it more in case of females, UTI. Obesity is also one more important anatomic factor because of the pressure and other related symptoms. The factors compromising the immune response, for example, aging. As the age progresses, we do find this problem even more due to other immunocompromised conditions like HIV or diabetes mellitus, in which it's very difficult to get the infection out of the body. Functional disorders like constipation, voiding dysfunction due to detritus sphincter dyssynergia. Others that we see, other special conditions in which we find this quite more, pregnancy in case of multiple sexual partners and other infections, sources of infections, poor personal hygiene, hypoestrogenic state, as we find it postmenopausal and other perimenopausal age group women, use of spermicidal agent and contraceptive diaphragm in case of women. So these are the various risk factors that you can see, whether it is an anatomic or a functional or neurogenic or anything that causes stasis or a foreign body. These are the various factors that we need to look up to find out the real cause, so that we simply just do not treat it. We also prevent by knowing the source of the urinary tract infection, so that we do not end up having the recurrence of it, because knowing the risk factor, severity, and the grade is equally important than treating the disease. Risk factors for UTIs, the factors resulting in compromise of the normal host defenses to bacterial colonization, are an important step in the pathogenesis of UTI. The various risk factors, as we've already discussed, it may be iatrogenic or due to drugs, like we have an indwelling catheter post-surgery, or due to any other cause. Various antibiotic use, like rampantly we are using antibiotics without culture and a sensitivity, use of spermicides or various other diaphragms and other devices. Behavioral, like voiding dysfunction, holding the urine for a longer time, frequent or recent sexual intercourse with multiple sexual partners, and other kind of poor personal hygiene. Anatomic or physiologic, as we discussed, vesicoureteral reflux. Female sex due to shorter urethra in special conditions like pregnancy or diabetes mellitus. Genetic, it may be a familial tendency also, genetic predisposition being there in many cases. Susceptible uroepithelial cells for the bacteria. There can be certain uroepithelial cells very susceptible to infection. Vaginal mucus properties, that is also very specific and has a genetic predisposition. Indwelling Foley's catheters provide an ascending route, as we can guess from it, for perineal bacteria to enter the bladder. Recent antibiotic use disrupts the normal bacterial flora at vaginal introitus, allowing uropathogens, for example, E. coli, to colonize. Spermicides cause irritation and attachment sites for E. coli. Voiding dysfunction, how does it work? Causes increased post-voidal residual urine volumes, which allows more time for bacterial proliferation. Frequent or recent sexual intercourse may introduce bacteria into the urinary tract. Vesicoureteral reflux, it causes urinary retention again, allows more time for bacterial growth. The retrograde flow also allows bacteria to ascend to the kidneys. Females have a short urethra, 4 centimeter versus 25 centimeter in in males. Pregnancy results in progesterone-mediated smooth muscle relaxation to the bladder and ureters, and compression of the ureters by the uterus. So these are the pathophysiological mechanisms behind all these risk factors leading to UTI. Both result in urinary retention for increased bacterial growth. UTI occurrence tends to cluster in families, as already told. Susceptible uroepithelial cells secrete less IgA, which is the main humoral defense mechanism at the physiologic mucosa. Properties of vaginal mucus may allow E. coli binding more readily. So that differs from patient to patient or person to person. Bacterial entry, understanding of the mode of the bacterial entry, host susceptibility factors, and bacterial pathogenic factors is essential to tailoring appropriate treatment for the diverse clinical manifestations of UTI. There are 4 possible modes of bacterial entry into the genitourinary tract. It is generally accepted that periurethral bacteria ascending into the urinary tract causes most UTI. Most cases of pyelonephritis are caused by the ascent of bacteria from the bladder through the ureter and into the renal parenchyma. So these are the various possible modes. As we can see, pathogen colonizes in the periurethral area and ascends through the urethra upwards towards the bladder. Fimbria allow the bladder epithelial cell attachment and penetration. Following penetration, the bacteria continue to replicate and may form biofilms in the uroepithelial region. Following that, we have an ascension. Once sufficient bacterial colonization occurs, bacteria may ascend on the ureter towards the kidney. The fimbria may aid in the ascension process. Bacterial toxins may also play a role by inhibiting peristalsis, reducing the flow of urine. Infection of the renal parenchyma causes an inflammatory response called pyelonephritis. While infection of the renal parenchyma is usually the result of bacterial ascension, it can also occur from hematogenous spread. So we can have an ascending infection also. We can also have an hematogenous spread. If the inflammatory cascade continuing and the damage occurs leading to interstitial edema, this may lead to interstitial nephritis causing acute kidney injury. So a small, simple urinary tract infection, if not treated properly, undertreated, not diagnosed or underdiagnosed, can lead to various ascending problems and forward problems if there is more invasion of the bacteria slowly ascending into the urinary tract up to the kidneys. Part of the urinary tract affected, if they are kidneys or acute pyelonephritis, what are the signs and symptoms that we are going to see? Upper back and side flank pain, very typical, high fever, shaking and chills, nausea and vomiting. These are the few common signs and symptoms of acute pyelonephritis. Coming to cystitis, we'll have pelvic pressure, lower abdomen discomfort, frequent and painful urination, and sometimes blood in the urine. Coming to urethra or urethritis, we would have burning with the urination or some kind of discharge. Clinical manifestation, lower urinary tract symptoms are experienced in patients who have UTI of the upper urinary tract as well as those confined to the lower tract. These symptoms are related either due to bladder storage or emptying. These symptoms are decided in 2 parts, the emptying symptoms or the storage symptoms. Coming to the emptying symptoms, weak urinary stream, hesitancy, difficulty starting in the urine stream, resulting in a delay between initiation of urination by relaxation of the urethral sphincter and when urine stream actually begins. Intermittency, interruption of the urinary stream while voiding, post-void dribbling, urine loss after completion of voiding, urinary retention or incomplete emptying, inability to empty the urine from the bladder, which can be caused due to atonic bladder or obstruction of the urethra. It can be acute or chronic. or dysuria, that is difficulty while voiding or pain during urination. So these are the various emptying symptoms, that is a weak urine stream or hesitancy or intermittency, post-void dribbling, urinary retention or incomplete emptying, very typical of as described by the patient, or difficulty while urination or pain. Storage symptoms, urinary frequency and abnormally frequent, that is maybe more than 7-8 times in a 24-hour period. Urgency, a sudden, strong or intense desire to void immediately, usually accompanied by frequency. Incontinence, involuntary or unwanted loss or leakage of urine. Nocturnal, waking 2 or more times at night because of the need or urge to void. Nocturnal enuresis, complaint of loss of urine during sleep. In children, it is called bedwetting. So these are the various storage symptoms that we can see. How do we diagnose the urinary tract infections? First, by collection of the urine. It has to be a clean catch midstream specimen. Usually a morning sample is preferred. A specimen obtained by catheterization, or if a sexually transmitted disease is suspected, a urethral swab for STD testing is obtained prior to the voiding. So these are the various ways how we collect the samples and send it for diagnosis. When there is acute onset of urinary symptoms like dysuria, frequency and urgency, we find out these things. Otherwise, healthy woman who is not pregnant, low risk for multi-drug resistance. We consider uncomplicated cystitis, no urine culture needed. We consider a simple mode of management. A woman with a history of or risk factors for STD, we definitely go for a culture and routine analysis, as STD evaluation or a pelvic examination also to consider uncomplicated cystitis or an STD. Male with perineal pelvic or prostatic pain, we do consider acute prostatitis, a urine analysis and culture, and also urological evaluation. Patient with indwelling urinary catheter, we should consider various things: exchange or remove the catheter, urine analysis and culture again, blood cultures if fever persists. All other patients, we can consider complicated UTI and go for a urine analysis and culture and address any modifiable anatomic or functional abnormalities that we have discussed earlier. So this is how we are going to progress in a flow chart if we are going to check it. If there is acute onset of a back pain, nausea, vomiting, fever with or without cystitis symptoms, again, we are going to suspect our pyelonephritis and other reasons. Otherwise, healthy woman who's not pregnant, considering uncomplicated pyelonephritis, outpatient management. All other patients, we go for a urine culture and a blood culture, considering pyelonephritis or acute prostatitis in case of males. Systemic symptoms, if we are going to find fever, altered mental status, leukocytosis, especially in elderly patients and patients with spinal cord injury or immunocompromised patients with no alternate diagnosis. We consider complicated UTI, consider other etiologies also, go for a urine culture and a blood culture. If no urinary symptoms are there, but a positive urine culture in patient who's pregnant or a renal transplant recipient or patient undergoing invasive urological procedure, we consider ASB, asymptomatic bacteriuria, go for a screening and treatment, whatever is warranted in that case. A positive urine culture in all other patients, we consider asymptomatic bacteriuria, no additional workup or treatment is needed. Positive urine culture in patient with indwelling catheter, we consider a catheter-associated asymptomatic bacteriuria, no additional workup or treatment, remove the unnecessary catheters and treat accordingly. Recurrent acute urinary symptoms, otherwise healthy woman who's not pregnant, we consider recurrent cystitis, urine culture to establish the diagnosis, consider prophylaxis or patient-initiated management. A male patient, we consider chronic bacterial prostatitis, we definitely go for a urological evaluation. Coming to the differential diagnosis, which is very, very important because lower abdominal pain and urinary symptoms can also be due to various other reasons. An acute urethral syndrome, which occurs in women, is a syndrome involving dysuria, that is pain during urination, frequency, and pyuria, which is dysuria pyuria syndrome, which thus resembles cystitis. However, in acute urethral syndrome, unlike in cystitis, routine urine cultures are either negative. Urethritis, it is a possible cause because causative organisms include Chlamydia trachomatis and Ureaplasma urelyticum, which are not detected on routine urine culture. So this is another thing, and also sometimes a swab can be taken for culture of that specific area around the urethra. Non-infectious causes like anatomic abnormalities, that is urethral stenosis, physiologic abnormalities like pelvic floor muscle dysfunction, hormonal imbalances like atrophic urethritis, localized trauma, or GI symptoms and inflammation. So we need to rule out all of this to establish UTI. Coming to the management part, when it comes to uncomplicated UTI, according to the flowchart and all the various severities and the degrees that we saw, by categorizing them, if we find it as to be uncomplicated UTI, we definitely start with antibiotics, very preferably nitrofurantoin or a trimethoprim sulfamethoxazole. Adequate fluid intake, we ask the patient to take plenty of oral fluids. Urinary analgesic, it can be any combination of agents or phenazopyridine or etc. Counseling about the risk of recurrence and reduction in risk factors. Urethritis, sexually active patients with symptoms are usually treated presumptively for STDs pending test results. A typical regimen is ceftriaxone 250 mg IM plus either azithromycin 1 gram or doxycycline 100 milligram BD for 7 days. Coming to cystitis, first-line treatment of uncomplicated cystitis is nitrofurantoin 100 milligram BD. For 3 days, it is contraindicated if creatinine clearance is less than 60 milliliter per minute. So renal function tests are also warranted. Trimethoprim sulfamethoxazole 160 or 800 milligram per oral BD for 3 days. These are the usual simple regimens that we follow in our OPD. Acute pyelonephritis, antibiotics are required. Outpatient treatment with oral antibiotics is possible if all the following criteria are satisfied. Patients are expected to be adherent. Patients are immunocompetent. Patients have no nausea, vomiting, or evidence of volume depletion or septicemia. Patients have no factors suggesting complicated UTI. Ciprofloxacin 500 milligram per oral BD for 7 days. A second option is usually again trimethoprim or sulfamethoxazole 160 or 800 milligram BD for 14 days. In case of non-pregnant women, we consider empirical treatment with an antibiotic for otherwise healthy women aged less than 65 years, presenting with severe or more than equal to 3 symptoms of UTI. We explore alternative diagnosis and consider pelvic examination for women with symptoms of vaginal itching or discharge to rule out PID and other related, maybe candidiasis and other related symptoms. Use dipstick tests to guide treatment decisions in otherwise healthy women under 65 years of age presenting with mild or less than equal to 2 symptoms of UTI. So age is a factor whether a woman is less than 65 or more than 75, seeing the severity of symptoms, the number of symptoms related to UTI, and to rule out other pelvic inflammatory disease and fungal and mixed infections of the vagina. Antibiotic treatment of lower urinary tract infection. We do not treat non-pregnant women of any age with asymptomatic bacteriuria with an antibiotic. We treat non-pregnant women of any age with symptoms or signs of acute UTI with a 3-day course of trimethoprim or nitrofurantoin, but usually antibiotics are continued for a long time as prescribed by doctors. Very rarely are we giving it for 3 days. Care should be taken when prescribing nitrofurantoin in the elderly who may be at increased risk of toxicity. So we need to look up the age before rampantly prescribing a nitrofurantoin to anyone. We should take the urine for culture to guide change of antibiotic for patients who do not respond to either of these drugs, because most of the cases we do find resistant specimens. Symptomatic bacteriuria, standard quantitative urine culture should be performed routinely at first antenatal visit. We confirm the presence of bacteriuria in urine with the second urine culture. We do not use dipstick testing to screen for bacterial UTI at the first or subsequent antenatal visits. We treat the asymptomatic bacteriuria in pregnant women with antibiotics because we cannot let it go. Why UTI is more common in pregnancy? The answer lies in the physiological changes occurring in the urinary tract. During pregnancy, as already discussed, the progesterone release causing the smooth muscle relaxation. Physiological changes in the kidneys. What are the changes we see? Kidney size increases approximately by 1.5 centimeter. There is dilatation of the renal calyces, giving a hydronephrosis-like picture. It may cause urinary stasis, thus increasing the risk of pyelonephritis. There is increase in GFR and renal flow rate. These changes affect the pharmacokinetics of the drugs used in treatment. So it definitely matters. We really need to look up to the kidneys. If you're having a recurrent infection and other kinds of symptoms, there is no harm in putting the probe and seeing the kidneys or doing a renal function test or to know the condition of it. Physiological changes in the ureters. What do we find there? We find growing uterus compresses and laterally displaces the ureters at the pelvic brim. Ureteral compression and effects of progesterone causes significant ureteral lengthening, dilatation, and kinking. These structural changes may give rise to hydroureter and sometimes obstructive nephropathy, increasing the risk of infections. So as we can see, we can have a posterior urethral valve or a bladder neck obstruction. We can have thickened bladder wall with diverticular, hydroureters, and hydronephrosis. This is how we can have the sequelae. The physiological changes in the bladder due to persistent pressure of gravid uterus on the bladder. There is marked thickening of the bladder trigone as already shown there. There is also increase in the bladder pressure from 8 to 20 centimeter of water. Due to above reasons, there is significant vesicoureteral refluxes during pregnancy, causing ascending urinary tract infections. So these are the various causes why we find UTI more common in pregnancy. Grade 1 into a non-dilated ureter, grade 2 into the pelvis and calyces without dilatation, grade 3 mild to moderate dilatation of the ureter, renal pelvis and calyces with minimal blunting of the fornices, grade 4 moderate ureteral tortuosity and dilatation of the pelvis and calyces, grade 5 gross dilatation of the ureter, pelvis and calyces, loss of papillary impressions and ureteral tortuosity. Coming to the management, antibiotic treatment, as we have already discussed, we treat the symptomatic UTI in pregnant women with an antibiotic. We take a single urine sample for culture before empiric antibiotic treatment is started. A 7-day course of treatment, amoxicillin, cephalexin, augmentin, whatever is normally sufficient. Given the risks of symptomatic bacteriuria in pregnancy, a urine culture should be performed 7 days after completion of antibiotic treatment as a test of the cure. Coming to men, UTI in men are generally viewed as complicated because they result from an anatomic or functional anomaly or instrumentation of the genitourinary tract. Conditions like prostatitis, chlamydial infection, and epididymis should be considered in the differential diagnosis of men with acute dysuria or frequency, and appropriate diagnostic tests should be considered and has to be taken more meticulously than in case of women. In all men with symptoms of UTI, urine sample should be taken for culture. Due to the ability to penetrate the prostatic fluid, quinolones or ciprofloxacin rather than nitrofurantoin or cephalosporins are indicated. Treat bacterial UTI empirically with a quinolone in men with symptoms suggestive of prostatitis. 4-week course is appropriate for men with symptoms suggestive of prostatitis. Refer men for urological investigations if they have symptoms of upper urinary tract infection and fail to respond to appropriate antibiotics or have a recurrent UTI. So without much delay, we definitely need to take a urological consultation. Patients on catheter, we do not rely on classical clinical symptoms or signs for predicting the likelihood of symptomatic UTI in catheterized patients. Signs and symptoms compatible with catheter-associated UTI include new onset or worsening of fever or rigors, altered mental status, malaise or lethargy, flank pain or costovertebral anchor tenderness, acute hematuria. We do not use dipstick testing to diagnose UTI in patients with catheter. Antibiotic treatment, do not treat catheterized patients with asymptomatic bacteriuria with an antibiotic. Do not routinely prescribe antibiotic prophylaxis to prevent symptomatic UTI in patients with catheter. Criteria for selecting antibiotic in UTI: drug should be present in high bacteriolethal concentration as in blood, all fluids of urinary tract. For example, glomerular filtrate, interstitial space, intracellular space, extracellular space, afferent and efferent blood vessels of glomerular capsule, so that it's effective against all bacteria present in any part of the renal system. No residual infection persists even after cessation of the antibiotic therapy. That is how we are going to select the antibiotic. Drug should not be altered in its efficacy or detoxified by the liver or kidney itself. Drug should not be nephrotoxic. Drug should be present in same bacteriolethal concentration in urine when passing down in ureters and stored in bladder for viable time, that is around 4 to 6 hours before being voided. Drugs should be broadly effective against all common bacteria causing UTI. Efficacy of drugs should not be much influenced or altered by change in pH of the blood as well as that of the urine. Drugs should not cause crystallization or nidus formation for development of calculi. Drugs should not have wide margin of safety. Its bacterial lethal effect and toxicity to patient, particularly pregnant women and fetus in utero. Easy to administer, oral and or parenteral. Dose schedule should be simple, maybe once a day or twice a day. Bacteria should not be able to develop their resistance too early and too frequently. So these are the various factors we need to keep in the back of our mind while selecting an antibiotic for UTI, and simply not blindly writing the same antibiotic for all the cases, as we've already discussed in which case we're going to prefer quinolones, which case we're going to take cephalosporins, which case we're going to take a TMP sulfamethoxazole or a nitrofurantoin, and that too we need to be very, very careful the number of days, whether it's a 3-day course or a 7-day course or a 2-week course depending upon the drugs. And we need to repeat the culture in case of pregnant women and other women to see the test of our cure. Recurrent UTI, repeat urine analysis and consider urine culture and sensitivity testing. Antibiotic, 3 to 5 day treatment regimens of TMP sulfamethoxazole or nitrofurantoin. Sensitivity guided antibiotic. Urinary analgesic such as phenizopiridine or combination agent. Cranberry or lingoberry juice. This is very, very popular nowadays. A 200 to 750 ml or equivalent tablets are also available, which are having cranberry extracts and D-mannose, which definitely pull down or bring down the pain while urination and the ability of the bacteria to adhere to the uroepithelium as claimed. Adequate fluid intake, imaging study of the urinary tract in selected cases. So these are the various things that we are going to use in case of a recurrent UTI. Antimicrobial agents for genitourinary pathogens, the diagnosis, complicated UTI, the pathogens as we've already discussed time and again, E. coli, Enterococcus, Pseudomonas or Staphylococci. We need to be very careful about beta hemolytic streptococci in case of pregnant women. Choice of antibiotics, again fluoroquinolones followed by amniopenicillin, 3rd generation cephalosporins or aminoglycosides. Duration of therapy, 3 to 5 days after efebrile. Common antibiotic choices for UTI in pregnancy, nitrofurantoin, cefalexin, ampicillin, or an amoxicillin clavulanic acid preparation, amoxicillin trimethoprim sulfamethoxazole, usually the last choice as it is pregnancy category B, C. The rest are all pregnancy category B. So we usually go for the first 3 options that we can see here, nitrofurantoin of 50 or 100 milligrams 6 hourly or 12 hourly, cefalexin 250 mg 6 hourly or an ampicillin 250 mg 6 hourly or an amoxiclav or 250 mg 6 hourly or 12 hourly. Treatment regimens for asymptomatic bacteriuria and cystitis in pregnancy, we have already discussed it again. We need to avoid nitrofurantoin in G6PD deficiency, amoxicillin when there is increasing resistance, and also cefalexin when there is increasing resistance. We can avoid trimethoprim in the first trimester or in the last trimester, preferably. We can, of course, go for fosfomycin 3 gram single dose. It works really well, 1 sachet, 1 shot. And sometimes if it's severe, we can definitely repeat it after a week, maybe once or twice, as we do give. In a Cochrane review, comparing the effect of shorter versus longer duration of treatment, findings suggest that a single dose regimen may be less effective compared to a 7-day regimen. Usually that is the standard that we even use in our OPD, 7-day regimen. The authors therefore recommend the use of standard 7-day regimen, as currently no evidence exists comparing 3, 4 or 5-day regimens with 7-day regimen. Treatment regimens for asymptomatic bacteriuria and cystitis in pregnancy. Again, nitrofurantoin, amoxicillin, amoxiclav, cephalexin, fosfomycin, and trimethoprim. Recommendations in treatment of symptomatic UTI in pregnant women who present symptoms of an UTI. A single urine sample for culture should be taken before starting any empirical antibiotic treatment. Local guidance on bacterial resistant patterns should be sought to aid in choice of antibiotic, what usually we see in the culture and in that particular area. A 7-day course of treatment is normally sufficient. Given the risks of symptomatic bacteriuria in pregnancy, a urine culture should be performed again 7 days after completion of antibiotic treatment as a test of cure. We do not prescribe trimethoprim for pregnant women with established folate deficiency, low dietary folate intake, or women taking other folate antagonists. So we need to be very careful with this drug, trimethoprim. In women with pyelonephritis whose symptoms are mild or for whom close follow-up is possible, antibiotics can also be given on an outpatient basis. Pyelonephritis, the most recent Cochrane review of various antibiotic regimens for the treatment of pyelonephritis found no significant differences relating to cure rates, recurrence, incidence of preterm delivery, admission to neonatal intensity care unit, need for antibiotic change, and incidence of prolonged pyrexia for various antibiotic regimens in most of the included studies, except that cefuroxime achieved better cure rates compared to cephadrin and resulted in fewer recurrences. It is difficult to identify one particular antibiotic as being superior to the rest. However, evidence on effects of treatment by setting suggests that while outpatient treatment resulted in increased gestational age at delivery, babies born to inpatients had a significantly bigger birth weight. It is suggested that for pyelonephritis, after 24 weeks of gestation, the patient should be put on intravenous antibiotics until they have fever-free period for 48 hours, at which time oral treatment should be instituted for a duration of 10 to 14 days. So we definitely find the benefits of inpatient treatment than the outpatient basis treatment in case of the sequelae of pregnancy and the birth weight of the babies. Treatment regimens for pyelonephritis in pregnancy, again, ceftriaxone or azithromycin or a piperacillin tazobactam, cefepime. These are the various drugs that we can give intravenous form when pyelonephritis sets in. Urosepsis is the severest form of UTI with the most serious potential adverse outcomes, including death. Treatment is usually continued for 14 to 21 days, and failure to respond to treatment should trigger further evaluation for urinary tract obstruction or abscess, which necessitates drainage. Apart from antibiotic therapy, other measures must be undertaken to avoid the risk of septic shock. These measures include hemodynamic support. The goal is to achieve and maintain adequate tissue perfusion. IV fluids are administered initially and vasopressor medication if IV fluids fail. Parameters of adequate perfusion include pulmonary capillary wedge pressure at 12 to 16 millimeter of mercury, or a central venous pressure at 8 to 12 centimeter of water, urine output rate more than 0.5 ml per kg per hour, mean arterial blood pressure more than 65 millimeter of mercury, and a cardiac index of greater than or equal to 4 liter per minute per meter square. Respiratory support, hypoxemia, hypercapnia, altered sensorium, or a respiratory muscle fatigue signal the need for ventilator support. Metabolic support, in the initial few days, the desired blood glucose levels should be less than 150 milligram per deciliter. Euglycemia is targeted later. Notes on specific antibiotic classes in pregnancy. A number of drugs are excreted through the kidneys, making a number of them theoretically useful in treating UTIs based on potential concentration in the renal system. However, the pregnant state prohibits the use of an antibiotic where safety to the fetus or newborn is a concern. Where the benefits outweigh the risks, the antibiotic can still be used in the face of no other alternative. Trimethoprim and sulfonamides have the risk of neonatal jaundice if sufficient serum levels are present at the time of the delivery. The addition of trimethoprim increases activity, but trimethoprim inhibits folate synthesis, which is crucial for preventing neural tube deformities. That alone, along with sulfamethoxazole combinations, should be avoided in first trimester as well as after 32 weeks gestation. Several studies have not found increased risk of major malformations in case of quinolones or fetal musculoskeletal defects or spontaneous abortions or prematurity or IUGR or postnatal disorders in case of quinolones. Semisynthetic penicillins are particularly active against enterococcus. Ampicillin shows high levels of urinary concentration. Hence, its continued use, even with emerging resistance, is warranted. Addition of clavulanic acid, a beta-lactamase inhibitor, confers activity against beta-lactamase producing E. coli. Cephalosporins are considered generally safe to use during pregnancy, but the high protein binding capacity of ceftriaxone may displace bilirubin if given a day prior to delivery, predisposing neonatal jaundice, especially in premature infants. So we need to be careful with that. Cephalexin was associated with major defects in Michigan Medicaid surveillance study, although Hungarian case control study did not find teratogenicity. So it's better to be avoided. Nitrofurantoin, again, it's a FDA category B drug. It is specific for urinary tract infections, but we need to avoid it in case of G6PD deficiency. Prevention of recurrent UTI in pregnancy, postcoital prophylaxis should be considered in pregnant women with a history of frequent UTIs before the onset of pregnancy to reduce the risk of UTI. In one Cochrane review, close monitoring and a daily dose of nitrofurantoin combined with high clinic attendance rate was associated with a significant reduction in asymptomatic bacteriuria. Apart from pharmacological interventions, non-pharmacological interventions have also been used in the past for prevention of recurrent UTIs in pregnancy. However, the best approach is currently still not known. Coming to prevention, as we know, prevention is better than cure. We need to maintain hygiene, wash our hands before using toilets, wipe front and back after urinating or defecating, clean urethral meatus first while bathing, use washed clothes to clean the perineum, use liquid soap instead of bar soaps to prevent colonization, stay hydrated, avoid caffeine. Caffeine irritates the bladder, urinate before and after the intercourse. We should wear comfortable and clean clothing, preferably cotton material in case of summers, and consume a healthy diet. And also, as we know, cranberry is a very famous thing that has been coming up. Any form of I think a balanced diet and lots of fluids and fruits and vitamins and antioxidants are very, very important to prevent it and to prevent the colonization of bacteria. Very importantly, personal hygiene and to keep it dry and clean. That is the most important thing. So I think we have summarized quite a lot about UTI, but it's a very common topic, a very general topic, which we see. We find patients coming into the OPD, but we have to, as we said, it's a very simple thing, but we cannot write the same drug for the same number of days for all kinds of people, pregnant, non-pregnant, giving the age group that we are catering to, why we're choosing that drug, how many times are we getting the culture done, are we writing a proper urine analysis for them, or we are going for a renal function test and we are simply writing the same regimen for a recurrent UTI. We need to be very, very careful about these simple topics, these simple diagnoses that come to our OPD, so that we do not cause harm to the patient and we leave it untreated, so that there is a very bad prognosis and sequelae later on, or an ascending infection going up to the acute kidney injury or pyelonephritis. So it is a very important duty to treat the proper form of UTI with the proper dosage, with the proper antibiotic for the proper period of time, and also follow up and also check for other differential diagnosis and rule out and treat accordingly. So I think the last 1 hour would have given a clear picture about what to do and when to do and how to do. So I think I'll stop it here and we can finish.
Thank you so much, ma'am. Yes, ma'am. Thank you so much for giving a detailed and as well as crisp knowledge about UTI. So let me check if we have any questions from delegates. So, ma'am, one question is there, how much there is impact of HSV causing UTI? herpes simplex virus?
See, as we discussed, there is also differential diagnosis when it comes to various sexually transmitted infections or herpes simplex viruses and other things. So we need to, there can be a combination of both the infections. They can be cohabiting infections also together. So we need to rule out HSV also. As we know, HSV2 is very much prevalent below the pelvis in other regions. So we need to get that treated. We need if required, dermatology or a venereal disease consultation also, and not just term it as UTI. And we need to treat both the aspects if we find it. And we go for a complete urine analysis, dermatological consultation, and the history also of various other episodes of HSV infection coming up, and treat both of it. And there can be definitely presence of both and a link between both.
Ma'am, then second question is, according to you, what is the alternative treatment strategy to limit antibiotic use for antibiotic resistant UTI?
See, when it comes to antibiotic resistant UTI, of course, culture is a thing which would give us a clear picture about what antibiotic to use.
Yes.
It's not like a patient is going to end up having resistant to all forms of antibiotics, but I feel antibiotic specific targeted antibiotic treatment is definitely required. Besides that, if we want to adopt various other measures, we've told about various normal measures, but it is a complicated UTI. Those measures are not going to work unless the infection has been treated. But if it's a non-complicated UTI, of course, we can definitely go for other measures like hydration and having other analgesics or cranberry extracts or D-mannose to reduce the other kinds of symptoms. But I think a targeted antibiotic therapy is definitely warranted, or in case of resistance, maybe the period has to be chosen, the amount of dosage that we are giving. So I think that is required. And other alternative measures are not going to help much if already antibiotic resistance has set in. Of course, prevention is better than cure. We can avoid UTI coming up again and again by various measures as discussed. But I feel a culture sensitivity is very, very important to know what we are going to do.
Okay. And thank you for giving all the answers to these questions. And we are glad to have you on our platform regularly. And we would like to have more sessions with you on Shield Connect. Thank you, ma'am.
Thank you so much. Thank you.
Thank you, ma'am. Thank you. Nisanji, thank you.